o'clock. Welcome to the third meeting of the CBAS Stakeholder Workgroup. I'm Bobby Wunsch with Pacific Health Consulting Group, and I'll be facilitating the meeting today. We have an important group of people here in the room, and I'm sure we have a number of people on the telephones. So why don't we start by having members of the Stakeholder Workgroup who are sitting around the table introduce themselves, and then we'll ask members of the workgroup that are on the telephone to introduce themselves. So James, let's start with you, please.
James Kawakami with LA Care.
Great. Ruth Gay with the Alzheimer's Association of Northern California.
Rosalie Marchand, Escatana.
Shirley Plaza, Escatana.
Celine Regalia, Napa Valley Hospice and Adult Day Services. Lydia Missolidis, California Association for Adult Day Services.
Jeannie Smaller with Department of Healthcare Services.
Denise Peach with the Department of Aging.
Pam Oakler, Care for Health Plan.
John Shanty, Department of Healthcare Services.
Ed Long, Department of Aging.
Great. So let's hear if we have any members of the Stakeholder Workgroup on the telephone. If you could introduce yourselves, it would be great. Any members of the workgroup on the telephone?
Michelle.
Michelle, are you on the phone? I wonder if Michelle's on mute. Right here.
Ask her to speak in.
Michelle, can you introduce yourself?
Oh, Michelle said she's on the webinar, but she hasn't dialed in yet.
Okay. Okay, anyone else on the phone? That's a member of the work group? Okay, we expect a few more people to come in as the meeting goes on, but we're going to go ahead and get to work. We have a ton of work to do today. We have to finish going through the special terms and conditions from the waiver. We have to work our way through the SOPs. And our goal is to get through both of the documents before today's meeting is finished, so that at our next meeting, which is our fourth meeting, we are able to review all of the recommendations and confirm that the work group supports the recommendations, and also spend a good part of the time at the next meeting talking about what does the future hold for CBAS. And it's very important to us that we have time for that discussion. So I'm going to push us through this process as quickly as we can without stifling discussion. So just remember, it's me, and my goal is to make sure we get through this work. So the first thing we're going to do is we're going to hear from Denise and Jeannie about the feedback that we've gotten from stakeholders who have been sending in input. We're going to hear a summary of what that input is and how you can access the detail of their comments.
Okay, great. Thanks, Bobby. This is Denise. So I'll just give you first of all the numbers, and then I'll talk a little bit about the nature of some of the feedback in case you haven't seen any of it. And there's a bunch of new stuff that has come in over the last few days that I want to call your attention to. That'll be posted after today's meeting. So if you can start popping up the actual log. I'll tell you what we've got so far. We've had 86 comments or questions that have been submitted to the CBAS mailbox for the stakeholders process. 15 of those were during last meeting, and 11 of them have come in just recently in the last few days here. So some of them are not up on the web, so I want to bring your attention to them. So the main areas of feedback, for those of you who haven't looked at it, we had 27 comments or questions about authorization process, face-to-face determinations, eligibility, et cetera. So that was our number one area where we had providers and stakeholders and plans and whatnot submit comments. We had the next number is stakeholder process itself, and so I want to call attention to that. There were a number of questions, things as simple as can't we have the meetings at 1:30? It's easier for me. Those kinds of things, which I think the answer has been, no, we can't, because we're trying to work around CBAS program in particular, starting meetings at 2 to be observant of how program hours work in CBAS centers. So lots of things about stakeholder process. And then the next most popular comment or question area has been around CBAS program models. So people looking at things like flexible models and things going forward. So those are some of the highlights. I want to call your attention to what's up on the screen. This is a copy of the log that is, we have this format posted on our website, and this includes comments that have been received since our last meeting and the comments from our last meeting. And I want to encourage workgroup members, especially who have a responsibility to sort of represent these views from the larger stakeholders out in the community, to please take a look at these. There have been a number of really, really substantive comments, especially since the last meeting, which would track really well with what we were doing last meeting. So I'd encourage you to take a look at the new listing that we'll post later on at the end of this week. A couple of things I just want to call attention to. First, I want to give a shout out to Amanda Silas, who submitted a whole bunch of stuff recently. She's a licensed clinical social worker and somebody who has been tracking the stakeholder process. She gives a lot of really, really great feedback, and it echoes a lot of the sentiments that the work group has raised and other stakeholders recently about need to look at some amount of discretionary, non-duplicative eligibility processes with the plans. We talked about that last time. We're going to talk about it a little bit more today. She mentioned a number of things about ideas about care planning. So there's a lot of really weighty stuff that I think came in the last few days. I don't want to spend too much more time on any of this right now, but just want to call your attention to it. Lila's just showing you the format. Lots of things on that log, and I'd encourage the work group to take a look at it. Did anybody have any questions about anything that they've seen and making sure that we're incorporating the larger community into this discussion? Yeah.
So I saw the matrix that had the notes from the last meeting incorporated with, where you were handwriting on, Bobby. So is the one you're describing now going to incorporate those comments plus the stakeholder comments from everyone else and then on one master form? Is that what we should look for?
First of all, I think that we can do what's your pleasure. We're kind of staff to this effort, but what we've been thinking was we took the matrix from last time that we had given to all of you. The work groups input, the small work groups inputted their feedback on each of their sections. Then during the meeting last time, we took notes, and Bobby took notes, and we posted those notes up on the website. So we have now a matrix up there that has all the feedback today. So we have a stakeholder log that includes comments that people have been submitting all along. And we had not incorporated that into the larger document. So we have the log and we have the matrix. So we could incorporate it all and consolidate it if people felt like that was useful. I kind of feel like it'll just muddy things up. So, for now, I'd say I'd encourage the work group to just read through these things. They're sorted by subject area, and there's some really good ideas, and nothing will surprise you. It's all things that we've all been talking about in here. So that's some very creative approaches.
So it's two matrices we should be looking for and looking at.
Yes. I think that's it for you, Bobby.
So I just want to reinforce what Denise said. A lot of stakeholders who are not on the work group have taken a lot of time to follow these meetings and send in comments. So members of the work group really need to take responsibility for reviewing those comments, certainly before our next meeting when we're going to finalize the recommendations from the work group. Just a lot of thoughtful comments. So we had a few people who came in after we got started, so I'm going to ask Diane and Nina and Mallory to introduce themselves so everybody knows who's here. Diane?
I'm Diane Cooper-Puckett with the Peg Taylor Center for Adult Day Healthcare.
Nina Nolcox, Graceful Senescence Adult Day Healthcare.
Mallory Vega, Acacia Adult Day Services in the Orange County Adult Day Services Coalition.
Great. And did anyone, any members of the work group join via telephone that we haven't heard from yet? Okay, Robert, you're there? We know you're there. Do you want to say hi to the group? Okay, well, Robert and Michelle are on the phone listening in, and I know that when they have something to say, they will either write it in, and Jeannie will see it, or they'll speak so we can hear them. So, okay, we're going to move on now to talk about two important topics. two important topics. Somebody's jumping ahead here. One is we want to review the waiver amendment process and timeline, just to remind everybody how this is going to work. And then we promised to talk a little bit about the hierarchy of authority. So Jeannie and Denise, you want to start this?
I can speak on the waiver amendment process. We'll, after the stakeholder work group progresses along, we'll go ahead and meet internally with CBA and our executive team, and we'll work on putting together the fine-tuning the waiver. We'll go ahead and submit that to CMS, probably start negotiating talks with them prior to actually submitting the waiver, so we are on the same page. Submit the waiver 90 days before the final deadline, so we're hoping to have it submitted in May, so we can work through that process. CMS will have information that they'll want back from us. They'll have questions. Certainly, they usually have a request for more information. So we work with them throughout the 90-day process, and then hopefully have the approved waiver amendment ready to go by August 31st. Anything else?
Can I just interject that we're getting feedback from the audience on the webinar that they'd like us to speak up a little bit more?
So I was sure that was about to come. So. Okay, everyone in the room needs to speak loudly. And Nina and Diane have comments or questions for Jeannie.
Well, I just wanted to know if we could get a written timeline, with what you just described, something that kind of explains that. And
Sure.
that'd be great.
We can put something together and get it posted on the website.
That'd be excellent. Thank you.
Good suggestion, Nina. Thank you. Diane?
And I'm wondering, within that timeline, Jeannie, will we have a chance, the work group have a chance to see the final version before it goes to CMS? Because it looked like, according to the work we had planned, we weren't actually going to have a final version drafted prior to completing our meetings.
Oh, right. I think the expectation is that the next meeting, we're going to be finalizing all the recommendations, but when it comes to actual language, we have certainly been playing around with drafting different concepts and stuff, but as far as having actual language by next meeting, I don't think we have any expectations about that. So.
I think Diane's question was, before it's submitted in May to CMS,
okay.
would the work group get a chance to see the submission?
I don't see why not, that you can see the documents that we're going to submit to CMS. I don't see that, I don't see this as a big issue with that.
So I think
the answer is yes.
Yeah.
I think the only thing to remember about the submission to CMS is that CMS could come back and say no to number 5 and yes to number 6, but change it this way, and no to number 7, and how about putting this in instead of number 9. So I think we'll just have to remember that it's an iterative process at best with CMS. Good questions, though. Those are great. Lydia.
Just a quick one. Are the standards of participation part of the package that has to go in with the waiver? Are you going to talk about that when we get to the authorities?
I think the standard of participation is a document that the CMS requests when we submit the waiver. Okay, so it did not say whether this is required or not required, but it's very important that the waiver is an agreement between the state and CMS about this particular services. And so undoubtedly CMS wants to know who are the providers, how the provider selected, how the provider credentialed, and so on and so forth. So.
Good. Any comments from members of the stakeholder work group on the phone? Robert or Michelle, anything you want to add before we move on?
Not for me.
Okay, thank you.
And Michelle said no also.
Okay, thank you. Okay, so just a reminder, which I forgot to say when we started, there will be public comment at the end of the meeting, so any members of the public that are here, we'll look forward to your comments at the end of the meeting, and members of the public that are on the telephone can type their comments in and they will be read during the public comment period. Okay, well let's go on then to talk about the hierarchy of authority.
I'm supposed to pick that. And I want to pick that as a lay person. Okay, I'm sure that there's
Speak up, John.
I'm sure that there's a lot of refined details from legal counsels and things like that. But and we receive a lot of questions from Lydia on behalf of CATS about the different layers that we have. So let me do a very general description of the layer. Basically, there's federal and state law that we have to comply with. Period. Okay. So that's the foundation for all the things that we do in Medi-Cal. Then the next layer would then be the agreement between Department of Healthcare Services and CMS on implementation of the Medi-Cal program. And there's two components to that. One component is state plan benefits. Okay, these are benefits like hospital, physicians, nursing facility. Those are state plan benefits that need to be generically available throughout the entire state for Medi-Cal beneficiaries. And then there's waiver program, which is basically supplemental to the state plan benefits. Waiver program are for specific target population, different kinds of waiver from state wideness, and whether it's need-based driven, that means you can do an assessment and things like that. Those are the waivers. Okay? So that's why you have the 1950 home and community-based waiver. You have the 1115 waiver to do managed care. So these are all different kind of agreements that we have with CMS. But when the CMS review the total package, there's the state plan type of services and there's waiver type services. And this is, of course, subservient to federal and state laws. Okay, so whenever there's a state law change or whenever there's a federal law changes or interpretation of federal law changes, then you need to look at how the state plan operates and how the waiver operates to make sure that you come into compliance with all of those state plans. And a very immediate example that many of you may be aware of it is that CMS come up with the final rules for home and community-based care and what's a home and community-based setting. What would that do to us would be meaning that we have to look carefully at our assisted living waiver to see all the provider in assisted living waiver can live up to that standard. If not, we need a different provider set. Or we need to implement changes to the provider to make sure that those kind of things happen. The other thing on the state plan side, IHSS program is a state plan benefits. There's the new labor law, which is unrelated to Medicare, Medicaid, to interpret who are the employer of this individual, whether overtime is appropriate to pay those. So the state and federal law are the driving force behind the state plan as well as the waivers. Okay? And state plan and the waiver, the next level down will be contractual relationships. We have a demonstration program. Example would be like CCI, the demonstration program for the next 3 years in selected county. There's a state law directing the Department of Healthcare Services to look for those opportunities with the federal government to implement the state law. Okay? And out of that comes this three-way agreement with CMS, the plan, and the Department of Healthcare Services. And from that, the next layer down is the plan and the provider contracts. There's definitely boilerplate templates that is governed by not only what the Department of Healthcare Services require, but also require under the NOPS-Team license for some of the health plans that need to require NOPS-Team license. So there's different part of the state law that will affect those kind of contractual relationships. We do have a boilerplate from the Department of Healthcare Services for the CBAS provider defining the relationship between the plan and the CBAS provider per the settlement agreement. Okay? But then, besides the boilerplate, the plan do have some flexibility in terms of how to design that contractual relationship with local CBAS providers. So these are all different layers. Okay? Federal law and state law drive the state plan and the waiver services for Medicaid programs. And then underneath that, provider contract, managed care contracts, and underneath that, managed care provider contracts. Does that explain, in a sort of a generic sense, what are the driving force? Now, a lot of this can be very circular. Okay, if you can look at a CCI SB 108, it's the legislature directed department to go to CMS to secure that demonstration program, and subject to federal approval and subject to federal funding participation. Okay, so it can be very circular. So if we go to CMS and CMS says, no, we don't want to participate, we don't want to do that, then the question remains for the state legislature would be, do we want to use general fund money alone to do that? Okay, so it can be circular, okay, in that sense. So understanding is that when we have an agreement with the federal government through the state plan and the waiver, it's not only just describing the services, what are the benefits the individual should get and how they get it, but also is a agreement for federal participation. Okay.
John, let's see if anyone has any questions about the hierarchy that you've laid out. Yes, Nina.
Yes, can we have that? Yes. I tried to take great notes, but
And that would probably, we'd probably draft that, share it with legal, they'd have to review it. So it might take a little longer to make that one available.
thank you.
No, that's very helpful, John.
Yeah, although it will be in the summary of the meeting.
It will be in the summer.
Yeah. So.
Can I also just add, because we put in on these bullets on the slide, because those of you who are familiar with operationalizing a lot of what John just described, you're also familiar with the Medi-Cal provider bulletins, all plan letters, policy letters that come out of the department to clarify or elaborate on those rules, those federal and state rules. And then in addition to that, the last bullet refers to guidance that comes out through the Department of Public Health, through all facility letters, through the Department of Aging, for all center letters. Again, those should be sort of in the hierarchy as an elaboration of policies that are existing in state law.
Great. Lydia.
Thank you, John, for that. I think it's just helpful for us to keep that in mind as we think about what, like you said before, what's doable in the short term, mid-term, and longer term in terms of aspirations, and then also how these things interact, because the regulations, as many of us know, but some of you may not know, are going on 30 years of, including communication by telegram to licensing officers. That's my favorite. And so, we know that statute overrides regulations, but I'm still not really clear, maybe legal can help us understand, can regulations be overridden by these other contractual elements, something that's more current? And that's where things start to get a little fuzzy, because the regs are just, there's still a lot of relevant, good regs, but it starts to get a little confusing.
I'm sure that this is true for all the provider type and the healthcare systems. Okay, hospital has tons of regulations that can date back to
30 years.
Okay. So there's a lot of those kind of rules and regs and stuff like that that may need to be updated. Okay? And so I think that's definitely a very challenging process for doing that. So for adult day health, for CBAS, okay, I think there's a question about CBAS and adult day health center. Basically, CBAS is a provider type. Okay, it's a license type. Okay, and in the past, before the CBAS program is basically one and the same. It's an optional benefit under Medi-Cal, okay, which is part of the state plan. But with the launching of the CBAS, it's being put into the waiver section of the program. But nevertheless, that CBAS program is built on the basis of the adult day health center provider type. So whatever regulation govern the adult day health center, CBAS program needs to have that license to operate the CBAS program. So having said that, but also be very clear that adult day health center provider doesn't have to serve Medi-Cal beneficiaries, doesn't have to participate in a CBAS program. They can serve private insurance, they can serve long-term care insurance people, they can serve VA people, they can serve anybody. Right? So the fact that the adult day health center provider choose to become a CBAS provider, that's a decision made by the adult day health care center. So the adult day health center will continue to exist in respect of the CBAS per se. So I just want to, but I think in many of our minds in the history of adult day health center, those two things are so intertwined as a single thing. But I think in the transition to CBAS and putting CBAS as a benefit for managed care, it's only happening in the 1115 waivers.
Good. Thank you, John. Okay. Any other questions on this topic for John?
Why, I'm clear. Thank you.
Neither are dismissed. So now our work begins. So just as a reminder to everyone, our job was to review the SDCs and the SOPs and make recommendations on how they should change or what elements should be kept. And all of you participated in smaller work group discussions on different sections of the SDCs and SOPs. We went through the SDCs last time. We got up to SDC 85, and we're going to pick up where we left off in a few minutes. But in the interest of time, because I was worried that we might not get through everything today, I asked CBA and DHCS to put together some recommendations encompassing the work that your small work groups have done and the discussions from last week, and to kind of wrap those up into a series of topics that we could review. And then we'll go to the grids and see if we can get through those a little bit quicker. So I hope you'll forgive my prerogative as a facilitator in asking them to do that. But I really wanted to make sure that we would get to talk about the most important issues. Suffice it to say that the work that you've done we still want to talk about. So if you have comments on anything, we want to hear it, and that's the purpose of our meeting today. Okay? So we're going to get started with Denise and Jeannie, and we're going to go through a number of issues, and then we'll switch to the grid, and we'll catch up with the work on the two grids, the SDC, starting with number 85, and the SOPs, which we haven't started yet.
Okay?
Take it away.
Start? Sure. But I'm gonna kick a lot of them over to Ed and John because there's some meaty topics here, and I think that as we talk about which ones we can sort of take off the table or wrap up, or which ones you throw into consideration, I'll let them talk to them. So, so at the top of the list, we have talked about the need to add state statute references, and I think that the conversation last time was about the exact references not being appropriate for the STCs, but appropriate for the SOPs. We would clarify certain things generally in the STCs that they refer back to state statutes, but the actual numbers of Welfare Institutions Code, Health and Safety Code would be inserted into the SOPs. And I can tell you that we've already started to do all that. So, so that was a request from the work group, and so noted, and we will be working that up into the documents. The second bullet there is allow planned growth of new CBAS centers. We've heard a lot in this work group about access concerns and what's happening in the various places of the state where we don't have centers, and in areas that are underserved. And so this topic has come up again and again. So I will kick that one over to the gentlemen, see if they want to comment on that one and where we are with that. Okay, what are your notes, John?
I think basically is that what our understanding is that the moratorium of issuing adult day health center license has expired. The statute of that has expired, and for the current STC under the settlement agreement under the 1115, we're basically talking about transitioning of existing adult day health care center to a CBAS program for those people who want to join the CBAS program, and which will end in August. So from our perspective is that September 1st come by, if there's a provider in certain county who want to basically say, I'm applied for a license to do an adult day healthcare center. There's no process of stopping that. Okay. Now, what we hope and value is that those centers are developed in geographical areas that there's indeed a need. Okay. But when a person applies or when a provider applies for adult day healthcare license, we have no understanding what the intention is to serve the Medicare beneficiary or not. So that license will be issued by the Department of Public Health, right? Then the next step is that the operator of that adult day health center make a decision to join the CBAS program. And this will be going through a credentialing process done by CBA to become a Medicare provider, right? Now, under the current and future intention, including CCI contracts and stuff like that, for the 1115 waiver, CBAS will be a managed care plan benefit. So let's say, for example, in Siskiyou County, there's a new adult day health center established. The provider decides to be a CBAS provider. Partnership Health Plan, who's the Partnership Health Plan in Siskiyou? I think so. No?
No.
I'm just making it up.
Centene and Anthem.
Centene, okay.
Centene and Anthem. It's the two plans.
The two plans will have to include CBAS as a benefit for the member in those counties. That's where it is. Okay? I think the key point thing is that from our perspective, that it's important to address the access issue in county where there's not enough access for adult day health center and CBAS. And that's the mechanism we need to find some way to do that.
So are you talking about some sort of standards for getting new CBAS? So are you talking about setting some new standards in place?
Well, this is definitely, yeah, at the state level. But this is outside of STC in our discussion. This is totally outside of STC. Okay, so this is, again, the 1115 STC made very clear. CBAS is a managed care benefit where CBAS provider exists. So you need to start with an adult day health center license, willing to participate in CBAS, there's a managed care plan, and that's where the contracting happens.
Okay, let's just stop there for a minute. Thank you, John, and see if anybody has any questions. Diane or comments? And then Celine.
John, as of today, if there were no existing CBAS center in a county where there is managed care, are they able to extend unbundled services to people who are in need of CBAS in that county as they would have if there had been a CBAS center and that CBAS center had closed?
Right, I think that's we keep looking at this issue, and let me give you my interpretation of that. First of all, we need to talk about what's the need of the beneficiary, rather than what is a bundled service or what's not a bundled service. Okay, basically that in county where there's no CBAS center, the plan is presented with a member who has a level of frailty as described in the CEDP. Okay? So irrespective of whether the CBAS or no CBAS, the plan has a frail person. The question is, what's the plan going to do with it? Okay? So the plan has responsibility to provide whatever the plan cover benefits to that individual. So it can be home health, it can be medical services, it can be whatever. Okay? The plan do have responsibility to coordinate care with community resources. In this case, in a county where it's not CCI county, it will be IHSS. Okay? All right? And other community resources that may not even be Medicare benefits. That's not covered by them. It can be senior centers, it can be local programs, it can be different programs in the community setting. The plan original already have that kind of responsibility. Does that make sense to you? So because they are dealing with a member who has a level of frailty, they have a certain level of responsibility, they need to take care of the issue in order to help the person to stay healthy or stay independent in the community setting.
Okay, but if it's a non-CCI county, if the person disenrolls from the plan, once they're nursing home certifiable, and that goes back to the state.
Right, that goes back to the non-CCI
So
county.
the plan's not responsible.
The plan's not responsible.
Celine, and then Lydia.
Why does this, so you're saying that they wouldn't necessarily have to provide a CBAS-like service as it's stated currently?
Yeah, but I
So-
think the question is why do we put, I think I understand in the settlement agreement, we have bundle and unbundled CBAS services, and the reason for the context of that is basically that there's an anticipation some CBAS center will close. What do we do with those individuals? Okay, that's in the settlement context. The question is outside the settlement context, why are we typecasting an individual, you are a CBAS beneficiary, you are not a CBAS beneficiary. Why do we do that? I wasn't quite sure how do we think about that, because what you're presenting to the managed care plan is one of the members with that level of frailty. The question is, what are they going to do about it? Okay? They don't have to couch the need of that individual or the desire of that individual in the context of CBAS bundle service. That's what I'm saying. Okay? So I think the concept of bundle and unbundle, it does have its role in the current STC. But I think that the big question for us is that, do we want to look at our beneficiary and typecast, oh, this is a CBAS employee or excuse me, CBAS potential CBAS participant. So I think those are the kind of issues that we need to work through. Not saying that, you know, there's services necessarily existing in the community in order to provide that care. What we hope for is basically there's a chance to develop more adult day health centers in areas that there's no adult day health center, and we make good use of those resources as CBAS program.
Thank you, Lydia, and then Ruth.
So the insight that I got from the last meeting was when Sonia, for partnership, said that the way that unbundled services are defined today, because of the settlement, allows partnership to purchase things that they otherwise have no authority to purchase.
No, that's not true.
Because that was,
That's
she's
correct.
coming from partnership, so that was sort of a new understanding that she was describing. So if that is not true, then the plans need to be aware of that, because certainly partnership has that understanding. And I don't think anybody's talking about like categorizing people. It's like what is the scope of services a plan's authorized to buy?
Okay.
And in my mind, I want to make a distinction between that concept and within CBAS, the bundle of services, and then the desire by some plans to buy unbundled services within the center. And I'd like to begin talking about those as separately billable services to distinguish between the vast array that a plan may be able to buy that's whatever
That
universe is, and then CBAS, let's start talking about separately billable, because then I think it'll lessen the confusion that we have.
Good point.
Yeah, good point.
So, John, I think just to clarify for everyone, the comment that Sonia made from Partnership Health Plan, unfortunately she couldn't be here today, at the last meeting, and your understanding of the current situation. Could you just restate that for everyone?
I think the crux of the question that Lydia has is really basically that what did we authorize, allow the plan to buy for services that may not be normally described as a medical benefit?
Right.
Okay? You hear different verbiage from the department about, no, they cannot do that, yes, they can do that, no, they cannot do that. Okay? I think the principle is basically this. The department decides, based on historical information, what services are normally medical services and how much did we pay for it. We use that basis to set a rate. Okay? So in the CBAS situation is that we look at historical data, average day, number of days of attendance is 2.85 to 3 days. You know, we use those kind of information to come up with a dollar amount built on the basis of $68, something like that right now, $68, to come up with a rate to give it to the plan or incorporate the cost of CBAS into the capitation rate of the plan. So that's our relationship with the plan. Okay? And the plan go around and basically depends on what the plan is responsible. And you're looking at me, you should answer that question. But
I still have questions about what you do. I want you on direct dial.
So the plan has responsibility with their members. The plan has a fixed capitation resources and a certain amount of risk. Putting the person in the hospital, putting the person in the nursing home, putting the person through the emergency room. These are expensive undertakings. So the plan have all kinds of programs to basically, can we reduce those? Okay? So it's really talking about outcomes. That's why you have disease management program that the department did not pay for. You have diabetic program that the department did not pay for. It's not a normal medical services per se. There's no dollar amount historically to create a rate to pay the plan. Okay? So the plan do have a lot of flexibility to say, for the purpose of helping the beneficiary to stay in the community and avoid the next emergency room or next hospitalization or the next nursing home placement, let's buy something. Okay? That's totally at the plan level flexibility to do that. Okay? The department does not pay that. Now, when the plan does that, okay, I'm looking at it. Look another way. But I think the important thing to know that is that when plan comes to the department for rate setting purpose, then they will be basically presenting the financial information. This is how much we spend on this beneficiary. This is how much we spend in this category of services. The department does have the rights to basically say, hey, you are buying everybody a car. It doesn't make sense. Okay. I'm using an extreme example. Okay? So you are buying something that is not medically necessarily proven. Okay? And you cannot show me a result that indeed whatever you purchase produces the outcome that you have anticipated. The department reserves the right to make those judgments and basically say, hey, we can include this cost in your rate setting. So that is our relationship with the plan, different from the plan relationship with the local providers. Okay? The plan does have a lot of flexibility to create things that not normally in the Medi-Cal benefits. And that's the whole point of pushing to managed care so that there's more local flexibility and local understanding and try to create the necessary components of services to help people stay in the community.
Good explanation, thank you. So we're going to hear from Ruth and then Diane, and then we're going to try to wrap this up and move on because we have many topics like this to talk about. Ruth, go ahead, please.
It's more of a question, I guess. So if you take an area, let's say that's underserved, and it is also does not have a managed care program going forward right now, so I'll just pick Fresno off the top of my head because I don't know what's going on in Fresno. Okay? So if somebody wanted to start an adult day health plan in Fresno, they have to apply to the department and get licensed for adult day health care. And then they have to apply separately for a CBAS program.
Right.
Right. And our criteria for eligibility are very frail elders. At-risk replacement is the term that I had always heard in terms of there was a criteria at-risk replacement. Is there, as Fresno is then developing their managed care plan that's going to roll out, is there a disincentive for them to support a CBAS program going forward in their area? Because if they have somebody that's at risk for placement and there's no CBAS, they can place them and put them outside their system because they're expensive people. Because by definition, if they're at risk for placement, they're also at risk for hospitalizations, that kind of thing.
Medicare.
Exactly. But so what I'm wondering is are there other political things that can influence when we start talking about the expansion of CBAS centers that might incentivize or disincentivize the growth of this program based on either criteria that they would then still be held responsible for, or not, or, and I guess my flip side of that question is are there ways to build incentives in for plans to have that, a CBAS, for instance, in their community? Because they meet the criteria for at risk for hospitalization or at risk for multiple hospitalizations, or maybe have already started down that road. And are there ways to build that kind of criteria in as a qualifier for people to get into the CBAS program? So I realize that's kind of a convoluted question, but I didn't know if there's other things involved in the expansion than just the simple process of applying. And are there politics involved at the community level that might influence that in that space?
Well, I think you are talking about incentives, okay? And I think a good way to say that incentive for the managed care plan to behave appropriately, okay, would be you take all the medical benefits and integrate them into one single application. This is what we're trying to do in CCI. In a county like Fresno, in which Medi-Cal plan has only very limited responsibility, do not have the Medicare integration, okay? So they have a limited set of responsibility. We only take care of people who are our members and who, if the plan is not responsible for long-term care, they would definitely not look at CBAS. Okay? Absolutely not. If they're not responsible for Medicare hospitalization, they won't think very much about their long-term care needs. If we still have our current model of two-plan model with nursing home have only 2 months of responsibility for the plan, they can just enroll the person right out, and the person will be dumped back into fee-for-service. So again, the incentive is really what we are trying to do as a department, is try to integrate both all the traditional medical services, but also begin to integrate all the long-term care services, in which CBAS is the first one to go, and we think that is going well. Okay? But the next one will be IHSS, the next one will be nursing home, no longer than 2 months, but really entire process. Okay? And so really basically is that if you want incentive, you really have to take Medicare, Medicaid financial integration, you have to take all the different services, so there's no what I call escape route for the managed care plan. Okay? Then everything is basically lined up. Then the pressure will be basically how does the local provider, physician, CBAS provider, and other providers, and the managed care plan think about the need of the community and create those kind of response that may include let's build more CBAS. Okay? So that's the outcome of that. So right now, today, or maybe even a year from now, Fresno is probably not going to get there yet. Okay, so it will continue to be a county with a specific responsibility, a specific population. It may not have the Medicare, Medi-Cal integration. We may make CBAS a benefit of the plan, but the plan may not have the incentive to utilize CBAS, but other than just a benefit that they're administering, okay, according to whatever rules that we gave the plan. So it's very different stages of development, and then you have to wait to see how this process evolves. But if you want to politically support this, it's basically you're supporting the CCI implementation. You're supporting the CalMedi Connect implementation, that we have all the different pieces are integrated. And it's a big experiment.
Can I add one thing? And you need to be able to show.
Speak up, Pam.
Oh, I'm sorry. You need to be able to show the ROI, because that's how the plans operate. We need to see that whatever it is that you're talking about, maybe unbundling or what services you want to provide, you need to talk to the plans to see if they want to buy it, number one, and is it cost beneficial to do that?
I think the world that we are in healthcare is basically is that we need to ask for what's the patient outcome. It's not enough to say we want accessibility per se, okay? But it's basically is that what's the value of the service to the beneficiary or to the plan member in terms of so that we can help them stay healthy, so that we can help them stay outside the hospitals and outside the emergency room and outside the nursing home. I think the role of the CBAS undoubtedly has to think about not because CBAS exists, we have accessibility, but really, what is the outcome? Okay, so can CBAS participants have lower number of nursing home admissions, lower number of EDUs, lower number of hospital days because they are monitored day in and day out, which I believe they will. Okay, but nevertheless, you need to demonstrate that. Okay, so it's not just a matter of accessibility per se. People have the right to access, but it's really assessing what services for what outcome.
Thank you, John. So we're going to take a comment or question from Diane, and then we're going to move on to the next topic.
I just wanted to get a clarification, John, relative to the question I asked you before. It comes in part because of the expansion into the rural counties. And out of all of those counties, only 4 of those counties already had a CBAS center in place. So what I was wondering is, did that, when you were describing the increment included in the capitated rate for CBAS, does that apply throughout all of those counties, or is that only true if there's a CBAS center in the county being served by the Medicare managed care?
Right now, it's very simple. Right now, it's basically that in those counties with no CBAS, there's no CBAS cost base to be included in the capitation rate. So the plan does not receive anything.
So if there, that's what my question related to when I said, in those counties, is there an opportunity now for people to receive unbundled CBAS-like services as defined in the settlement? Or is there no provision for that because there was no CBAS center there to begin with?
There's no CBAS there.
Okay, thank you.
Okay, so let's move on. We're going to keep slogging our way. We're just starting. I'm going to ask John to try to compress his teaching.
Thank you.
And answer the questions in fewer words. We have a long way to go. We love hearing what you have to say. Just remember that. Okay, let's go on to the next issue. So we've covered the statutory references to the standards of participation. We've talked about growth. Let's talk about the nonprofit provider provision that's in the STCs.
Okay, so the feedback that we got from the work group so far was that there was some amount of discussion within one of the groups that there wasn't quite total consensus on the nonprofit provisions, but I think that the overwhelming feedback has been that there's a desire to delete those nonprofit provider restrictions. So for review, for those of you who are familiar with it, in the standards of participation, there was a policy stated that the department was going to, at some point, implement a restriction on providers so that they must all have nonprofit legal status, and that provision has not been implemented, and there has been no sort of date set for doing so. And so I think it's been the consensus of the group that we'd like to see it just deleted altogether.
I think that's one well taken.
Anybody have any comments on that issue, questions? Yes, Rosalind.
Question.
Thank you.
With Espeton is now a member of managed care.
Yes.
Now, am I to understand that we are at risk here for losing?
No.
Not losing managed care, but we're trying to find a better way to make things more effective with CBAS and Medicare. I'm concerned about Medicare because recently she had a diagnostic testing, and the lady said that she wasn't covered because they didn't take Anthem Blue Cross. And so we had to stand there for more than a half an hour for her to tell us, well, I said, well, she has Medicare. Oh, do you have that? So that's what I needed to get some clearance on.
Yeah, good. No, that's a great question. So let's see, Denise, John, Laura, who would like to just clarify for everyone the scope of the benefits?
I think if you are a Medicare beneficiary enrolled in a supplemental plan, that is a Medicare plan, CBAS is definitely a benefit. It's covered.
And that's not going to go away.
It's not going to change.
Okay.
And your status as a Medicare beneficiary will continue also, and they kind of run parallel to one another. at this time in Sacramento, because Sacramento is not one of the CCI counties where integration is going to happen, if you choose. So I think you're set for the time, for the next couple of years, till CCI expands. Good, great question, though. Thank you for asking that.
And then you should still have those benefits
Right.
across, even
Exactly.
in future. The
Just the
benefits would be
delivery.
there.
Thanks, Diane. Okay, ready to go on? Anything else on the nonprofit status? Okay, go ahead,
So the next
Denise.
bulleted item, we got some feedback the last couple of meetings about adding some kind of quality metrics, provider quality of care standards into, I'm presuming the SOPs, because we've kind of made a distinction that that's where the things regarding the providers and what the providers will be doing in the program belong. So I think that that's an idea that we need a little bit further fleshing out. We're going to be talking about SOPs today. But that's an idea that has been brought forth by the work group.
So we're going to come back to that when we get to the grid on the SOPs.
The next slide, top of the next slide is create a new STC section for plan provider relationships. And so one of the things that was our actual homework since the last meeting was to start crafting some language that would capture this. I think that where we're leaning at this point is in our efforts is that I think that we believe that the STCs is the place for more description about what the plan's responsibilities are with regards to contracting with providers, with regards to arrangements for sort of alternative or flexible services program model, as we've been talking about, and then any kinds of care planning liaison and care coordination. That we're going to articulate that, and we have some very drafty attempts at that that we've been working with. Nothing for sharing at this point, but working on trying to put together that section in the STCs, and then a corollary section in the standards of participation that will capture the provider's sort of piece of that provider-plan relationship. So the summary there is that, yes, we heard you. We think it's a great idea. We're working on putting some of that language together, the STCs being the place for the plan piece of that, and the SOPs being the place for the providers to talk about everybody's relationships.
Does that make sense to everyone?
Mm-hmm.
Okay. So that will come up again when we review all the recommendations at our next meeting in March.
Next one up was, we've heard a lot from everybody in this work group and from stakeholders out in the public about plans having more discretion regarding conducting of eligibility determinations for the purpose of eliminating duplication, better coordination through the HRA the plans are doing. So we've heard a lot about that, and I think that if anybody wants to jump in, Ed or John, on that subject, I think the point is well taken, and I think that we're looking at ways of creating that kind of discretionary process.
And that will be included in the STCs if there's a change in that wording. That's a question.
Yeah, I believe that the STCs would be the place because that's where
The
progress are
plan.
now. Of course, in that hierarchy discussion that we were having earlier, that's also a contract issue. So DHCS specifies to the plans what their responsibilities are with regards to the eligibility process for CBAS in the contracts. So if there's any changes, that would be a downstream change that we have.
I think plan is also coming back to us to basically say, hey, how do we streamline and improve this process? Okay, undoubtedly, the important part of it is that for a new person coming to CBAS or coming to the plan, and the plan did not know who the member is or is new to the plan, there's no information on a person face-to-face was absolutely critical. Okay? For quality of care issues, for appropriate use of resources issues, and stuff like that. But I think we want to provide as much flexibility to the plan as possible to make it part of the policy and procedure that they would do for the CBAS provider, doing face-to-face and doing reassessments and stuff like that.
Thanks, John. Pam?
I have a question on the face-to-face. Given the enormous amount of assessments that we're going to be doing, many of them involving face-to-face with CBAS or MSSP-like, if we can consolidate all this into one, saying just a face-to-face needs to be done.
Right. Period.
Right. I think the important point is that the plan knows the beneficiary. They know the beneficiary, and that's information on the beneficiary. They can then decide how to get the proceeds. Otherwise, we would just do assessment with no services.
Killing them with assessments.
Yeah. And we'll come up with universal assessment too, right?
Okay, so any other comments on the face-to-face assessments? Okay, let's go on to the issue of unbundled services.
Okay, so we touched on that when we were talking about new CBAS providers and growth. So I don't know if there's anything more to say here. I think we all left the last time, I think, at a sort of a point where we weren't all sure we were speaking the same language about unbundled, and I think that we still see a little bit of that in the discussion around unbundled in the context of that Lydia brought it up with flexible model, where we're looking at CBAS providers who provide pieces and parts of CBAS program and are allowed to do that out of the CBAS center, that being one of the things that we were sort of grappling with last time, but that's not the unbundled issue as we see it in the STCs currently, which had to do with transition of the ADHD to CBAS program and whatnot. So I don't know if we need to belabor it anymore, but this is an issue that you guys were telling us last time that you wanted to see retained, and I think it's been our position that we were a little bit needing more information, to hear more information about why that was the thinking, and so there was more conversation we were supposed to have today.
Nina?
Yeah. I have some concerns specifically around the language of unbundled and what that, kind of like what Denise was just saying, and what that means to different people. I have some concerns that the baseline understanding of what we do was really kind of taken for granted, I think, at the beginning of this process. And the reason that I say that is because of some of the comments that I see inside of the matrix from some of the people on the committee, which leads me to believe that maybe they don't really understand our model of care and how it works and why it works, and the core services versus the separately billable services like Lydia just described versus unbundled services. And so I have some concerns that maybe there's some knowledge deficits.
So, Nina, how do you think it would be best for the group to have this discussion to make sure that everyone is kind of talking from the same level of knowledge?
Yeah, it's really interesting because I had a plan out to me and another leadership center in Los Angeles back during the SPD transition, had a plan come out. We took them to a center, we toured them, we gave them a PowerPoint presentation, and it wasn't until they saw a mock chart that it was like, oh, the light went on. So I'm not sure that those are, you know, case studies possibly, maybe some, I think, Diane, what were you?
Well, one suggestion would be actually at the outset, I had thought about the fact that we who are in the centers every day and we see the depth of what's going on for people still often have difficulty, you know, as Nina's saying, fully describing that until we can sit them down and show them, you know, an example of somebody who has, you know, had multiple hospitalizations, has severe, you know, mental illness, a whole range of health issues. And now that they've been attending the center for a while, they look healthy, they look good, they look whole, and so you can't walk into the center, see that person, and realize that person was in that top 1% super utilizer of services, because the comprehensive services have helped them to really improve. So, you know, as we think about our model, I think that, and going forward, part of the desire is to ensure that what those comprehensive services accomplish as a package is really understood, so that additional services would be additive, but that we are not hamstrung in trying to do the job for that top 1% that we can do via our full model. And so being able to even you know, bring some case examples here, as Nina said, or present some information to the committee to just help the whole committee to see inside what's going on within a CBAS program might be one way of doing this. And Conversely, also, then I think that would lead to interesting conversation about relative to when the managed care provider is putting services into place, how that can dovetail with identifying the need for the CBAS program.
Good point.
And finally, just the conversation around duplication, and with working with this population, IHSS and CBAS that's not duplication, and so those kinds of conversations. That's another example of where there may be some confusion, because if you think that that's duplication, then you definitely are lacking some information.
Yeah, really good point. So maybe as part of so we've got two issues, I think. One, we've got the STCs as they relate to the transition of the program from ADHD to CBAS. And then we have the discussion that we're going to have at our next meeting, which is about what are the options for the future. The transition's over, the settlement's over. What does the comprehensive services look like? What do the separately billed services look like? What does the future hold? So I think as we start to plan the next meeting, maybe this would be a good place for us to tap back to you for a couple of case examples that would help us kind of jump off into the discussion of future and future services. So I think that would be great. Okay, Lydia, did you want to add something?
No, it was really covered, but I would, dovetailing to what you just said, I'd like to ask if we could provide even just a short written summary of our community-based telephone project in light of the discussion we just had in these examples.
Well, one second, Pam. That would be great, I think, and that would certainly fit perfectly into our discussion for March. So let's do both. We'll have written and we'll have a discussion.
Okay.
Go ahead, Pam.
So I want to just bring something up that I don't know if all the plans feel this way, but we really know very little about what you do because very little information gets conveyed from you to us. I think we shared the last time, I think Beverly was sharing, that we know more about what a skilled nursing facility does and how they take care of our members than we do with CBAS because there's almost no communication coming back. So there's things that have to happen, and it's like we were told we had to contract with every center. Well, as plans, we know that the best way to do this is to get centers that are providing, good quality standards, the highest quality, and then we drive traffic to those. But it was difficult when we said we had to take on the whole lot, whether they were providing the quality or not. So there's a lot that needs to happen in terms of, I don't know if it's required reporting. I know that as a plan, we need to take responsibility. We need to make sure that we require the reporting that allows us to capture the great work that you're doing. Because as far as we're concerned, it's a black box. We really don't know what you do. It can be glorified babysitting as far as we're concerned unless we have the report, unless we have documentation to show, are you doing therapies? If so, how often? What's the result? These kind of things. And I think you're going to find that once the lines of communication get opened and once there's the ability for the plan to pick and choose which centers to contract with, it's going to, it's going to raise the bar, and I think it's going to create a different program.
Good, thank you. Okay, can we move on?
Yes, certainly. Okay, so next up we had discussion about, a lot of discussion last time about how we were going to continue the importance of continued access monitoring. We heard from a number of stakeholders about that, and coupled with this idea of some different reporting requirements than what we have now. We have reporting requirements throughout the STCs, and we talked about doing some streamlining of that, and actually we're going to talk about that, I think, top of the beginning of the review of the STCs, so we have some information to share with you on that. So we've heard a good deal of concern about continued access monitoring, which sort of weaves into the discussion about what is the access and how do we ensure that we have new centers as we need them. So we've gotten a lot of feedback about that section.
We're going to start when we get to the charts in a few minutes with 85, and that's the beginning of the reporting and monitoring section. So we're going to come right back to that. Okay, IPCs.
We've also had request that we establish a work group ongoing beyond the charter of this group to do the R&D on a revised individual plan of care, one that would take into consideration the care planning responsibilities of the plans. We had a long discussion about that last time. I think Mark talked about the corporate versus the different business sections. And so we talked about how we can retool the current IPC for CBAS so that it might better integrate with the managed care plans IPC. So we would assume that that would be work conversations we have next time about future initiatives.
Right. Okay. Okay. Few more comments.
And then the next item refers to further conversations that people are saying that they feel we need to have, and that would include discussion about rates and how that relates to access and availability of the services that people need, and then any legislative changes that may be necessary based on what's happening. So these are just sort of, this is sort of a placeholder for conversations that will undoubtedly take place at the next meeting regarding what we need to do to make all of these changes.
Okay, so again, this was an attempt to summarize what's ahead today in our work, and I hope it was helpful. I want to acknowledge that Viviana is here and joining us, and we're glad you're here. We're going to now switch to our grids. I'm going to put the grid up on the, here's the grid. I've got help today, and that's great. So everybody wants to turn to their STCs. And we're going to start where we left off, which is number 85. And 85 to 95 are the reporting and monitoring requirements in the STCs. So let's everybody get their grids out so everybody can follow along.
I don't know if this would be appropriate going back to what Pamela was talking about.
Could you just speak up, Selene?
I don't know if this would be appropriate related to what Pamela was talking about in terms of the communication between the plan and us, but I don't know if it would be possible just to look at a sample of what's in the statute around what they have to have in their plan versus ours so that we have their context as well as us having our own context of what that means.
And are you talking about for the IPC discussion or just in general? The IPC discussion.
In general, I think that, if we're talking about care coordination and collaboration, we need to know what's driving them and they need to know what's driving us, so to be able to see that in some framework would be really helpful.
Good. So let's have that for the next meeting. And I know we keep putting stuff into this future discussion, but I think that's an appropriate place for it. Okay, so everybody has their grid in front of them. So here we go. So we're going to start. We asked the state to organize some thinking about 85 through 95, the STCs related to reporting and monitoring.
Okay, so I'll start, and please jump in and correct me if I get anything wrong here. So one of the things that Jeannie and I do after every time these meetings are over is we go through a mad dash of trying to do all the homework that we said and commitments that we agreed to in the meeting. So one of the things that we did,
and they've done a great job doing that.
Was start conversations internally about where we might put this streamlined reporting section in the current STCs, or in a way working of them. And what would need to be included and what would need to be excluded in the streamlining efforts, because there's a lot of reporting requirements that you guys saw last time throughout the STCs. So, so part of what we are looking at is incorporating it into possibly 95J section, and which would be about provider oversight, monitoring, and including it to expanding it to include reporting. And then adding in there some language that, that specifies that our reporting activity would be associated with and consistent with the rest of the 1115 demonstration waiver quarterly progress reporting. So, so I think right now where we have a lot of pieces and parts of reporting that we do to CMS that are about different pieces of the waiver STCs, that we would look at bringing it completely in alignment with the rest of the quarterly reporting, which in reality is much of what's happening, is that we're incorporating our CMS reporting for CBAS with everything else. So that's basically the summary of what we were looking at doing. So that includes things like new enrollments, new eligible determinations, people being served, number of providers, et cetera. So, so at this point, I think that that's all we're prepared to share as far as what we're thinking and what we're playing around with in the reporting requirements, crunching everything down to put it in under that one section that we now have that would make it consistent with the 1115. In addition to this, and Ruth, if you would go ahead and pull up, we heard last time from the work group that there was a great deal of concern about continued access monitoring and continued monitoring of what's happening with the provider community. And so what we want to show you is what we're putting together at CDA for a new dashboard that we'll put up on our website, and we hope this will address a number of the reporting concerns, thinking about the STCs as being the place where DHCS and CMS make an agreement about what needs to be reported, and that they're going to ask us to report what they want us to report. And that in addition to that, we want to meet the community's need for having information about the CBAS program. So the dashboard that we're going to put up on our website is this is sort of a prototype for it, and we need to make sure that we get all of our buy-off from all of our leadership and legal and everything. But we're going to populate it with a bunch of information about providers and participants. So we have a center overview button there. We have a help me read them, I can't see them from here. Distribution of centers, there we go, thank you, expand it. A distribution of centers button, center services, and demographic makeup. And we also are going to pop up some, because we want to get closer and closer to transparency. That's our goal with what we're doing with regards to oversight, is to share things like the frequency of certain division practices that we see and issues that we see with centers. So we're working on populating our website with greater and greater levels of information. So here's the next page that we're walking through. Again, a center overview that we can update monthly that includes total participants served, total medical, and for those of you in the provider community, you're used to seeing these. We give them to you when we have meetings and whatnot. And but this would be a monthly refresh of our database. So we have number of Medi-Cal served, number of private pay served, newly eligibles in a given month, newly discharged, average daily attendance, number of managed care versus fee-for-service. So we can refresh these really easily off of our database. So that's our game plan. We actually, Wilbert was chomping at the bit to get it posted before the meeting today, but we had to get a few more buy-offs internally on some things. So it's actually pretty ready to go. So, and then dropping down this graphic that you see there that we'll have up on this page. This is a graphic that we actually provide to CMS quarterly, and it has to do with the number of operating centers, closures, reopenings, net gain or loss, and the total number of centers. So we'll pop that up there monthly. We keep scrolling down. These are the center services, and this comes off of our participant characteristics reports with the types of services that are being provided, to go to what Nina and Diane were just talking about in relation to Pam's comments. You know, what's happening behind the CBAS Center. This is some percentages. Who's getting physical therapy, skilled services versus skilled nursing services, what levels of medication assistance do people need. These are all things that we collect from the providers now, so we're working on getting those things available to everybody, again, keeping in mind what we might have as constraints with PHI release. So if you keep scrolling down, so again, this is just sort of the template for what we're doing. You guys, many of you have seen this map before, distribution of centers around the state. So we have a map that will show you where the centers are, where there are no centers, where there's a county with one center, where there's a county with less than 5 or more than 5. So you can see that distribution at a glance. And again, we've made this map available to people, but we're going to pop it up on the website and keep it refreshed monthly so people know what's, you know, have a finger on the pulse. And then scrolling down, I think we have one more page, demographic makeup. Again, this is some data that we have to populate from our participant characteristics, and we have to, some of this cross-references with DHCS data. That's getting harder for us to get because of the paid claims data changing with fee-for-service. But at any rate, age and gender data and diagnoses and some things, again, providers give to us on their participant characteristics. So we think this will be really helpful as a regular stream of information you can have about the providers. And then this is just CA oversight data. This is about the types of work that we're doing, how many centers we visit in any given year, how many follow-ups we do, reconsiderations because we have major problems, et cetera, the types of and nature of deficiencies and the frequency of things. So again, this is all sort of a draft template. We want to show you that we are trying to meet everybody's stated need for having their fingers on some better data. So I think we're going to be able to get this up and running in the next month, provided that our leadership that agrees with everything we've sort of templated out here. So I think that's
Right. So any comments about the concept of the dashboard, not the individual items, and the reporting and monitoring changes that are being proposed? Diane?
Well, I have some requests. The geographic nature of what's going on out there, particularly because I can look at our area and I can see how things are being. There isn't clear information. We have a service area that's Butte, Glen, and Tehama counties, and that's part of my question. Relates to my question to John, because it sounds like Tehama and Glen have now kind of had CBAS wiped out, services wiped out in future under managed care for them at the moment, because it wasn't recognized as part of our service area because our center sits in Butte County. So one of the requests I have is that there be continued stakeholder input in order to ensure the accuracy of the information, and also that there be a geographic breakout of some information. With apologies to Los Angeles, there are so many centers there, and so that represents almost like one area of what's going on in CBAS. For the rural areas, or the primarily rural areas, it's a whole different picture. And I think it's important to be able to see that, and also so that we can ensure continued access in counties like Tehama and Glen to our services. It needs to be identified that we serve those areas.
Great feedback. Thank you, Diane. Lydia, and then Ruth, and then Nina.
And we could probably spend all day, because this is really very exciting that you're thinking about a dashboard. I've dreamt of that for a long time.
Yeah.
And so I think the only thing
Now you can dream of something else.
The only thing I just want to throw out right now is I think it would be interesting to get feedback from the plans about what kind of metrics they'd like to see for the public, and that would be relevant to them. And I think to put some context around all of this, our long expired county data book, remember Laura when we had that grant that really never got fully utilized? It would be really interesting to put some frame around this with maybe county data around number of 65 and older who are in low income. I mean, just some interesting demographic statistics to kind of put in context. There's probably some things that plans would be really interested in. I think it would just be nice. Maybe this is another little work group that come together that of data.
And also things we've talked about is to look at capacity sorts of issues relative to population data in each of those counties or service areas. So you're talking about the population, and then you're talking about either license capacity or some other metric that speaks to relative to the population with X characteristics, the service capacity of the centers that are there.
So this was presented really as a concept. It's not a finished product yet, so these ideas are great. We're going to move quickly to hear from Ruth, Nina, and Viviana, and then we're going to keep going.
First, I just wanted to commend you guys. I think this is an amazing first outlay. I understand it's a draft, but it's amazing and it's wonderful and very helpful. One, again, I know it's always easy to keep at it, right? But one of the things that I know we couldn't get at very well is when programs closed, we didn't know what happened to the people very effectively. And I wonder if there's a way to capture, I guess one question we might want to ask 5 years from now is, did people actually die going through the course of this program and never were institutionalized? Could we actually look at data that kept people at home longer as a result of this? And if we just captured what happened to them next, whether it was a facility, hospitalization, they deceased, moved away, whatever. I think it might be nice data for us to have at some future point as things expand. Anyway, anyway, I just wanted to say that this is a really wonderful first step.
Thanks, Ruth. Nina?
And I think I wanted to kind of piggyback on what Lydia said and also say that that's great. I'm thinking that with the participant characteristics, I was just wondering, we do gather the information that we're asked to gather and put it on the forms, but maybe there's some information that the plans really want, or some things that are going to help us, really substantiate our evidence-based practice. Like an example, simple number of hospitalizations, number of hospital admissions, or some things like that, medication errors, or some of the things that are inside, using the HEDIS, and some things that really might, the plans might really embrace. So looking at, just kind of reevaluating what we're looking at when we look at the participant characteristics, and making sure that it's in line with what's needed for everybody. Yeah.
Great point. Great point. Viviana.
Really good. Thank you. I was looking at your indicators, and I'm wondering if you have any tracking of actual impacted indicators, such as the program was designed to achieve A, B, C, D. So that type of outcomes, do you have how many individuals were retained in community by this program? Do you have any expectations like that for your programs? I think that would be very important data that will be instrumental for advocating for expansion and for programs and for funding.
Ed?
I know that some of the discussion around that gets to quality and impact, and Lydia, I'd be interested to know what you think. I know that one of the issues with adult day health care as an intervention is that it's a collection of interventions, and it's hard to ascribe an outcome to adult day health care as a single intervention. I know that can be, I think it's a great objective, but it can be difficult to say because of adult day health care this happened, because there are many intervening variables.
Either to the positive or
the negative.
Yeah, but you can tease those out. I mean,
Yes, you can.
Yeah, but I don't. But the reason I'm mentioning that is, I think it's a good thing to aim for that will take time to do. But I don't know if you would concur.
Well, I think the reason it hasn't been done, because to do a truly kind of controlled experimental kind of an analysis is very, very costly, and there have been little studies that have been done. But Pam said the plans now have more data than they've ever had. The key is figuring out a study methodology that will make sense. It probably needs to be retrospective, and there are all those other intervening variables you mentioned, but all that, statisticians can figure all that stuff out.
Right.
So I think there's a way to do
I
that.
agree, it's very important. We have data people that can easily, design a program if we can put some resources to it or something, because we can do the pre and the post.
It's worth the whole
comparison.
Conversation around that. Yeah.
So, which is why I mentioned it, because I think as an objective, we have to think of it with those sorts of parameters around it, that it's not something that we can do immediately, but it's something we can make a commitment to do over the next.
There could be a pilot done somewhere,
Yes.
a plan that's willing to give put a little resources on the
That would
table,
be a
and
good
then
beginning,
pilot
because I have to tell you, as an stakeholder, I would like to see that the dollars I spend in places that are really giving me
the bank.
return.
Yeah.
So I know that you have done, and the reason that you have done a great job, you're still here, but we want to see what kind of impact you're making so we can continue to make investments. So if you can start with a pilot, that would be pretty helpful. I have another comment. I'm wondering if this type of tool might be helpful also to communicate where the openings are, to communicate wait times for the next face-to-face, so you can start collecting data as to how long it's taking for a client to be admitted to one of these programs. This would allow you to see also access issues, and I think 95 is related to that. You need to have adequate documentation on sufficient access.
Good points, Viviana. Can I piggyback on that real quick and say, if this is up on the CBA site, it would also be tremendously helpful if it indicates that these services are available to people who are not being served through Medi-Cal.
But so it's looked at both from the ADHC side and the CBAS side. And that's, even if you just look at it from the CBAS side, there are a lot of families who are going to end up being impoverished by paying for other levels of care. And if we can help keep them in the community based on, their own resources, because they can get easily to the programs, we can improve access for them as well.
Good point. So Denise, one more point, and then we're going to move. I'm going to summarize where we are, and we're going to move
Just
on.
for today, we wanted you to know that we're going to move forward. We'll make some tweaks based on some of the easier things that you guys suggested today, and we're going to post it, we hope, before the next meeting. And then we look forward to the conversations going forward about how we can improve it and build onto it, because we're changing our participant characteristics report sometime here in the very near future, so we're going to have some new data fields available. We're excited about being able to try to get some of those things that you guys want there. Great.
Well, there's obviously tremendous interest in the dashboard and a number of great ideas today to add to it. So this was great. Okay, so we're going to move on. We're going to go back to the SDCs. Thank you. So now we are ready for 96. We're going to take a break in just a couple of minutes, for about 5 minutes, so that we don't have to use the restroom. But I'm going to try to get through this before we take the break. I'll remember what our goal is for today. So 96 on page 27 starts with provider reimbursement and goes through 102. So I'm just wondering, Denise and Jeannie, any recommendations on the provider reimbursement, and then we'll hear from the group that talked about provider reimbursement.
Well, the most obvious thing I want to state is that we didn't have anything plugged in from the work group who was assigned to this from last time. So if you remember how we filled this graphic out, we included the comments that were submitted by the work group that was assigned to it. Some of you sent in comments that weren't in that work group, so I'd encourage you to share, but there was nothing that was up in that section.
So does anybody have any feedback on the STCs? And remember, our job is, should we delete the item? Should we change it? Should we keep it as it is? Any feedback from your committee discussions, or those of you that weren't on the committee but wanted to comment on this group of STCs? Diane.
Well, I need to get clarification from Denise, because our work group provided comments. And did you mean that you didn't ever get those comments?
So I believe what we did is we incorporated last time all of the comments that the work groups gave us. Oh, and Diane, you're right. Your group gave us comments, I think, after the meeting. So this was the template that we worked off of last meeting. So we may not have gotten your comment. Did you have this assigned to group number 4?
Yes,
This one was, okay.
Right, and I thought you had incorporated those.
Yeah,
I had assumed we'd see them today.
Right. We got all of yours into the SOPs, and we did not get them into this document, because remember, this was the document that Bobby was writing on and that we were moving things into, so we did not get yours on.
So would you like to review for us what your suggestions were on these, Diane, and we'll go through them, and I'll take some notes up here for you.
Yeah, sorry about that, Diane.
Oh, thank you, Denise, for letting me know. But what item are we starting with?
We're starting with 96.
96.
So feel free to just to comment on the ones that should be changed or that you recommend should be changed. You don't have to go through the ones that you don't think there's any change necessary.
Well, I'm gonna read the comment here, which was the consensus from our group. The rate needs to be increased. The 10% reduction needs to be restored, and a higher rate is needed, given that A, there has been no rate increase in years, while all costs, including utilities, transportation, staffing, and meals, have increased. B, the transition of almost all participants confirmed that CBAS participants meet a high level of medical necessity, i.e. they are confirmed as having a high level of acuity requiring more staffing to serve them. C, a number of programs have had to close due to the inadequate rate, and access has been impacted. D, given the cost of NIF placement in CBAS would provide cost savings to warrant the increased rate. E, in rural areas, there should be a rural factor to address the increased cost of transportation. By the way, that was not my suggestion. I want you to know. Again, this should be restudied to ensure access. And there was also a question about how the actuarially sound rate was set by the state. I wanted to add the reminder that fee-for-service does go on too, because there's on 97 relates to the fee-for-service payment. And so as we look at all of this, we just have to remember that we're going to keep having fee-for-service.
Mm-hmm.
So that's about 1,200 people that are not in managed care that are in CBAS programs.
And people across the state that will remain fee-for-service because they're exempted, they're outside of Medi-Cal managed care.
Okay, so good feedback. Any response from the departments to these suggestions? Ed?
And we'll just ensure that the more detailed comments that you provided are incorporated into
Yes,
what's
absolutely.
posted.
Thank you.
John, anything you want to add? Okay, so anybody else have any additional comments on 96 through, I think it's 102, before we move on?
Our group also had a question, as did group number 4, about how the actuarially set rate was developed and what data was used to generate that rate. I know actuaries are sometimes the black box to all of us too. And I would say generally, we didn't have as thorough a conversation as group 4 because this was divided between our group and their group, but we also had this similar concerns and noted that this language should be retained, but there would need to be changes. For example, under M, you combine, M with 97, and there would need to be some editing that I'm sure the staff are fully clear on what would need to happen. So that's all I would add to that.
Okay, that's good. John, do you want to say one sentence about the how the actuarially sound, quote, put that in quotes, rates are set by the state actuaries? Just so people know. One sentence. This is a very long and controversial discussion.
Sorry, I
One sentence.
It's historical fee-for-service spending for different services for the appropriate population. So if there's a due population, then we look at the fee-for-service spending for Medi-Cal benefits. So then you basically see that you spend a lot of time from inpatient costs because Medicare pick up the costs. However, IHSS costs are Medi-Cal costs. So it's really historical spending that we look at and set the rate for specific rate for the managed care plan.
So CMS sets the rate.
No, I think the department have a methodology to set the rate. The CMS approves the methodology, and then we go into do the very careful looking of population, identify the specific cover services, and then we set the rate based on that.
I know that resources are limited and time, but I'm wondering if there's an opportunity for the group to take a look at this, because it's at the heart of the existence of this program. I'm shaking my head and I say, this is a funny thing. This is not a doctor's office with a secretary. This is a program. And it's very difficult to distribute. Sometimes, depending on the region, you have only 20 clients to support a whole program. While you're in Los Angeles, you have 200. So I think that needs to be taken a look at the formula, how these programs are working. I don't know a lot about it, but my background is from mental health, and there we do things a little bit different. Yeah.
Right, setting the rate for the managed care plan versus setting a rate for the provider is different.
Okay, so we will, sorry, Nina, one more comment, and then we're going to move on to enhanced case management, number 103.
Well, I guess I just kind of wanted to reinforce a little bit more what Diane was talking about. And so when you think about where we are versus when the rates were the actuarially sound capitation rate and the information that it was based on information on adult day health care prior to the settlement, which changed the level of care, and we have now higher acuity. And so I just kind of wanted to mention that because that kind of seems to be possibly left out of this equation and might need to be integrated.
Well stated.
You open to put beds in your facility so you can keep them 24/7?
The plans might like that.
You need different level of staff to address those needs.
Okay, so I think that's all going to be taken under consideration. Thank you for adding that, Nina. Let's go on to enhanced case management. So this is the STCs that cover 103 to 123. And the recommendation is to delete these from the STCs.
Now this came from our group because in our thinking, it seemed that CCI law, this is where that, we keep coming back to the hierarchy, trumped this. So that was why we made that comment, and if that is indeed true, then you would delete it. If it isn't true, then one has to go through and figure this out a little bit more clearly. Because I don't know if enhanced case management stays when a center closes, if that's a value added for the the plans to be able to provide, or if it's already defined. So yeah, we didn't have enough information to have a complete analysis, but it seemed like this had been superseded by later developments.
So, Lydia, are you thinking even outside of the CCI counties?
No, we hadn't delved into that level of discussion. Yeah, we were just thinking that this seems to be an area that overlaps a lot of.
Let's come in. I think the enhanced case management is part of the settlement for class members that is not eligible for CBAS. Okay, so these are not CBAS individual, these are not CBAS eligible. And so the term of the settlement is ending August. This whole section disappears. Okay, so it has nothing to do with CCI per se. Okay, this is an agreement between our attorney and the plaintiff's attorney in terms of to provide the enhanced case management for people who are not eligible for CBAS. Okay, and it's over as of August 2014. And for CCI, it's a different issue. CCI is basically that we make a requirement for the plan to have certain level of care management. It's very well described in the three-way contract. And that's definitely a totally different undertaking.
And I think if you look at, 104 and 108 and several others of these, they specifically identify that this is a service through August of 2014, and then it ends. And we're talking about STCs post August 31st. So I think it would be slated for deletion. Okay? Okay, good. So I think, let's see, I think the next session is the quality strategy. And let's see if we can cover that, and then we'll take a break for 5 minutes. That starts on 124. Denise, you and Jeannie?
I think that I defer to John to talk about the larger quality strategy, but I think that just like our other reporting responsibilities that we're going to want to, with the CBAS STCs going forward, align everything with the responsibilities under the larger 1115 waiver quality strategy and reporting plan.
Yeah, and well, I just know that a lot of this is with managed care plans and with the overall waiver, 1115 waiver, so it's not really too much of our input.
I think I would suggest that this work will have a chance to take a look at the requirement of the CCI plan in terms of what they need to capture, and then derive some of that on the basis of what the managed care plan may be expecting of you. Okay, and I think take a look at that. But I think in general, what we have shared with in this SDC with managed care, with CMS about managed care plan quality strategies, and not only the basic stuff the managed care plan needs to do, but they have to select the right kind of provider, they have the appropriate size of the network, they have to have quality monitoring, they have to contractual relationships, on and on and on, basic managed care requirement of managing and building a network of providers. So this is what we basically share with CMS. But definitely, as you take a look at what CMS require and what for the CCI and what we propose, and there's quite a number. There's about 60 or 70 indicators. Some of them are long-term care related. Okay?
Yeah.
And so take a look at that, and then you have additions and suggestions. But again, the point earlier on basically is the focus on the outcome.
Mm-hmm.
Yeah. Focus on what did the intervention of CBAS produce.
That's the quality.
Right.
We still, though, this is a question, we still want in the SDCs some quality strategy. Just has to be perhaps rewritten. But the quality strategy needs to remain in the SDCs, correct? Lydia.
Well, I was just going to suggest, our group shared this with Group 4, and we didn't give you anything here or too much here because our note was this did seem to relate to the 1115 waiver, what CMS would want. We also, I haven't read the whole document, but I know CMS recently issued an LTSS quality strategy kind of a document report. So I would just like to ask or propose that maybe a small group get together who really like this kind of stuff and maybe do a crosswalk between what the plans need to get for quality, what we think we can offer, what CMS is expected to want. We can align all those things, and I don't think anyone's interested in 90 quality measures, but there's probably 4, 5, 6, 7, 8, 10 that are really important. I think our community-based health model is generating some really excellent ideas and data that might work in this structure. So is that something that we could do is put together a smaller group that really...
The one other thing I think, though, in part, and I'd have to check on this, is that the strategy plan goes through 2015 when the waiver renews, like you had said.
Right.
And I think that's in place through the end of the waiver, so I don't know that we can go in and amend the plan at this point because it's in play.
Even the 1115 waiver. Yeah, no, I wasn't suggesting that. I was just saying we need to kind of crosswalk those
to see what's there.
See what is relevant
Right.
in our conversation.
Mm-hmm.
Yeah, I understand that. And then there's a whole new 5-year renewal.
Okay. Does that make sense to everyone? Okay, I'm going to take back what I said. We're going to look at page 38, because it's the last page of the SDCs. We're going to finish this before we go to the baptism. So 151 to 158, that's the end of the SDCs. And this is the research study design. And we did have some feedback from the committee that worked on this, some suggested changes. Was this, whose group was this? Lydia?
Right, so we said identify common measures using TOPS. That's our web-based outcome measures benchmarking tool that's being re-engineered right now. It should be ready to relaunch pretty soon. For example, including quality of life measures and satisfaction tools, which we don't think have been designed for this particular population or implemented fully. So that was our, and we need more work to define the study design was the note I had. Did I put anything else there? And, okay, and then there were some suggestions about some other possible ideas. But again, this might be something that would fit with the other work group. If there's going to be a work group for the quality, it seems like this would fit in with that, perhaps.
Good. Anybody else have any other suggestions for anything on these STCs that they wanted to make sure were noted or got added to the revision and the later discussion?
We may have had some other comments that will get added in.
Okay.
We don't have to go over those.
Okay, good. Anything else?
Oh, Bobby, just the,
Yes.
provider reimbursement methodologies, which is all those unbundled, is this just sort of conforming then to whatever decision is made about unbundled?
Yes.
So we don't have to go
Yeah,
into
we don't have to go over all those pages. Okay, so congratulations. We got through the STCs. We're going to take a 5-minute break so that I can use the bathroom, and I hope you will join me. We're going to for those of you that are on the phone, we're not going to disconnect the line. So we will reconvene at, we're going to reconvene at 4 minutes to 4, and then we are going to work on the SOPs and see how far we get, and then make a recommendation of what to do next. Okay, we're taking So first of all, I want to thank all the members of the stakeholder work group for participating on the committees. The work that you did in the committees is the only reason we got through the STCs. So thank you for that. Now we're going to move into the SOPs. We have about 45 minutes. We're going to get as far as we can get today. We're going to keep pushing, see if we can get to the end. And then if we don't get to the end, I've got a suggestion for what we can do so that we really can spend the fourth meeting that we're together focused on future issues the majority of that time. But let's see how far we can get on the SOPs. And we have the SOPs up here on the screen, and I hope everybody has their version in front of them. So the SOPs are organized into about 8 major categories, and they were color-coded on the version that was provided to everyone. What I thought we would do, since we've actually covered a number of these issues earlier in the meeting, in the summary that Denise and Jean gave us, I thought we'd take each one of these major areas and see if we have anything we want to add or change as we work our way through, rather than going through 1, 2, 3, 4, 5. We'll cover the major areas. So these are the major areas. The first is legal structure, which is the nonprofit provider status and access issues. The next is eligibility and authorization. Then services, which go with the program model, services and staffing. Then we have the facilities. We have organization and administration. And then last but never least, the IPC. And again, even thinking of those buckets, we've discussed a number of these issues already. So hopefully we can push through this quickly. Okay? So let's see if we can start with the legal structure, the nonprofit provider status. I'll move this up a little bit. See if we can see the color coding. So is that green? Is that the color? Is the nonprofit status and access, that's the green bar? Is that right?
Yeah.
It's hard to tell up here when they color.
Oh, no, number 10 is IPC.
What is the legal status? It is green. The
It's
light
brown.
Right.
Yeah,
It's got
I
number
know.
6.
number
6.
3 and 6. So that's yellow and green, I think.
Yes.
If you have a color copy. But as you look here, you can see there's a color-coded bar on the far side, left, and far left. And that's what we're going to focus on. So we've already covered the issue about a CBAS provider continuing to be a nonprofit or a for-profit entity. Has anybody had any new thoughts about that since we talked about it a half an hour ago? Okay, we're going to keep going, man. There won't be any change there. And you can see in your version the different comments that people have made. Okay. So anything else in terms of the SOPs related to access? And I think access is the light green.
And I'd just say when we were doing all this color coding, remember this is just a function of trying to help people through
Right,
this exercise, so it might not feel so helpful right at the moment. But what we did was we sort of overlapped the issue of access under category number 3, that green one, with the nonprofit provider restrictions, because that would indeed affect access. So if you look at if you go by the lines instead of the colors, you see 9, 10, 11, 12. All of those are related to the issues of nonprofit provider provisions, 13 and 14, and we said that they would relate to access as well. So that's why those are coded like that. And if the direction is that we're moving towards not implementing that, depending on how this whole thing ends up, then that would affect both of those issues.
Great. Okay, and it looks like on those issues from the committee that worked on this, there were very few comments. to change.
I think they grouped all of their comments under box number
Right.
10 there, and they're pretty substantial comments, but they're just all grouped together. Yeah. Just say it once.
Anything more that needs to be said from those comments that hasn't been said yet? Whoever was in that committee? Thank you.
So it has the recommendation to change. Wouldn't that be to delete?
It should be eliminated. Nonprofit stuff should be
Okay.
eliminated.
I'm just looking at
Go
the
back to
access.
this,
Okay.
Yeah.
Yeah, they did check box change, but I think that the
Okay.
Okay, I think we've covered the provider status for sure. Delete. Okay. So let's go on to anything on the access issue. So Denise, which ones are those?
That's what I just explained.
Okay.
Those were all those number
Those were all
threes there, so they all
those
track.
are all the
together.
number
Yeah,
threes.
so I think we
Okay.
covered them all.
So they're covered. Okay. So let's go on to eligibility and authorization. Is that the next one? Sure, Viviana, go ahead.
Because this really is an issue of access. I'm sure that if the provider is not able to convert to nonprofit status, they will need to cut the program. So to prevent that, let's say in an area where there is none by one, what is being done to support providers of these services on nonprofit?
So it's my understanding there's no requirement to become a nonprofit.
Oh, okay, sorry.
So we're saying you can be a CBAS center
Or
if you're a nonprofit
Okay.
or if you're a private,
Thank
if you will,
I'm
commercial
sorry, I'm
entity.
Staying the same.
No, that's okay.
It's
Yeah,
gonna stay the
it's
same.
not changing.
Yeah.
Okay. So eligibility and authorization. Do you want to give a quick summary of
62,
that?
63, and 64, and they're on page 12 of your SOPs.
Okay, 62.
I think we're just going by topic.
We're
area
gonna
right
go
now,
by
so we're going to
topic.
come back to it. Yeah. So if you take 62, 63, and 64 on page 12, this is where we have a brief discussion in the SOPs about services being authorized through the TAR process, TARs substantiated by the IPC that's signed by the physician, and then the re-auth TARs every 6 months, again signed by the physician. So that's basically all that's in the SOPs on the subject.
Good. And the suggestion by the committee is no change. Leave these alone. Anybody have anything they'd like to add?
Wasn't there something about
No.
going from 6 months to 12 months?
Well, we've certainly seen that if you read the stakeholder input log that I encouraged you to do at the beginning of the show here today. There have been a number of comments about this issue, so I'd encourage the worker to take a look at it. And my nutshell summary is that people would like to see out in the field, anyways, some amount of flexibility on behalf of the plans to do sort of either a 12-month authorization or a 6-month rubber stamp for anybody that they'd already prior authorized. Some plans I've heard the suggestion that they'd like to have a rubber stamp process basically for anybody determined eligible who has under 3 days or under, and then anything beyond that they would have a regular review process by an RN. So I've seen a number of suggestions. I'd encourage you to look at the log. But as far as this group today, I think that's as much as I can share with you about what's in the input that we received out in the field.
And the committee that worked on this suggested no change. So based on that, does anyone who's read the other stakeholder comments, anyone have anything they want to add to this issue? Mallory, did you want to add anything? I mean, thank you for bringing up that comment.
Basically, I think it's worth looking at shifting to the 12 months with flexibility at least. There are times when 6 months would be appropriate. Certainly the plans would know when that is. Certainly the CBAS provider would know when that is.
Okay, Nina, did you want to add anything?
Well, I was just going to say that with some chronic conditions, we can anticipate decline rather than, and for, there's definitely a population that we serve that, 12 months is not, they're going to probably be, hopefully they'll be the same, but they will have likely declined. for a good portion of the population that we serve. And so I think that there lots of our people should be considered for 12 months, but it should be a choice. And I think the plan should have a choice. That maybe some of them should be 6 months and some of them should be 12 months. But that should at least be an option.
Okay, anyone else have anything they want to add?
I just make one point, since again we are talking about SOPs, and there are issues around this that are related to the STC, so we'll pick that up when we do the staff work on this. But I think that it's important to note that since the SOPs are about providers and the program rules, that you guys remember that the 6-month reassessments that the providers do would still remain the rule of the day. Still be the 6-month reassessments. Those are required to be part of the health record. So if the plan did or didn't want to obtain that, there would be some amount of discretion, I suppose, about what kind of paperwork they ask you to have. The program rules still are its own rules.
Oh, yeah. Lydia.
So I think this would be a really good discussion to have, maybe in conjunction with the discussion around the IPC and how in this new environment with managed care, what the desires are to document and communicate. We just haven't really had a chance to have that conversation in a meaningful way with all the rush of the CBAS transition. And I would, let's see, what is my note here on that? The treatment authorization policy when a beneficiary changes plans would also be something I would like to put on the table for that work group, because we are seeing some discontinuity of care and some confusion, and different plans have different policies around. Do they need to do a fresh face-to-face? Can they accept the IPC or the authorization from the other plan, and so on? I have a feeling there's going to be a lot more churning in the future, beneficiaries moving from plan to plan. So we could just add that as a discussion point.
It says Benny changes plans.
Yep. Churn.
For those of you that think I have really horrible handwriting, it's really a function of the board.
We know that.
Bobby, we've done an in-depth analysis.
Can't wait to hear the report. Okay, good. Those are great additions, so thank you. Okay, let's go on to, shall we do program facility next? So, which numbers are those, Denise?
Okay, I'm behind here. Okay, it's the dark blue for anybody who finds it first. Starting at item number 27, page 5 of the SOP document. And I think they're all grouped together.
Yes. Number
So these are all basically reflective of current licensing statutes, regulations around the physical plan, or mostly the physical plan, because there's a couple that seem a little bit out of place there. But most of them are about physical plan and maintaining of safety provisions and supplies and maintenance, housekeeping, et cetera.
And that goes to number 34, from 27 to 34. So any suggested changes here? Yes, Lydia.
Why is this in the SOPs? This is all licensing and it's in statute and regs. That was my question.
So, some of us remember back to the dark days of the rushing and the settlement implementation, and this was part of the work group's activities that was responsible for moving the program into CBAS. And I don't know, I was there, but I can't remember.
You asked a question about whether SOPs on the waiver or not on the waiver. This is the information requested by the CMS, and this is the way of explaining what CBAS is.
Oh, kind of in a summary fashion, even though it's in law,
So
right?
at this stage, we basically refer that everything is updated and regulations. CBAS program is still on the basis without day out, and that's just a communication to CMS.
I think that what I was sort of wisecracking about that is that I'm not sure why we selected these particular facility requirements versus others, because as you know, there's page after page Title 22 requirements for facilities. So somehow I think we were trying to distill them down, but it does seem kind of there was some selection of odd things.
And if CMS insists that they need a summary of health and safety, fine, no big deal. But I wanted to also maybe use this as an opportunity to see if there's any discussions going on among our state partners about the nexus of licensing and certification, where things overlap, where there are some barriers or constraints that we'd like to see removed in this new environment. For example, we talked a lot about flexibility, and the flexibility authority resides in the licensing regs under Department of Public Health, and we know Department of Public Health has basically done nothing to inspect these programs for all these years and defers to complaints and CBA. So is this an opportunity through this process to look at some of those conflicts and areas where it would make more sense to have CBA have certain authorities that currently licensing does, and they're not implementing them, or are, we're such a low priority at these points. Is there an opportunity here, or is this a different conversation?
I like to think there is, and then I'll let my boss know. But I'm not sure what it would look like, but I think that, we certainly acknowledge, what you're saying. I think that to look at the ADHC as being the base for program, like John described, and then CBAS certification for providing a program that, to some degree, how we oversee the CBAS program, and maybe sort of somehow trying to wrap around some of those licensing requirements a little bit more for those CBAS providers, and giving us a little bit more ability to do that, I think would be something we'd certainly be interested in. I don't know what the mechanism is.
Yeah, I don't know. I think there is an opportunity. I don't know if this is the mechanism to pursue the opportunity.
Okay.
I would just say this is not, okay? Because you can't say CBAS program is based on something that we have not even created at all, right? It's CMS who basically, but
Right.
So in the sense that for the purpose of this STC, whatever in the adult day health center law is whatever day health center law, that's what the CBAS program is built on. Okay. Now, if you want to change the law, okay, in order to reflect the private brain law today and stuff like that, that's a totally separate process outside of the STC.
Okay. Yeah, that helps.
So John and I are saying the same thing.
And I'm saying different things.
Well, you guys work it out.
So actually, we're all on the same page.
That's what matters.
Okay, so let's move on then. Anything else on the facility section? Let's move on to program model, services, and staffing. And that's items 15 through 25 and 48 through 62, approximately. So let's let's group them and start with the items 15 through 25, and then we'll go to the second set, which start at 48. So, and it looks like there weren't any suggested changes here.
We actually had one.
Good. Oh, great, Celine. Thank you.
So,
Which one?
We wanted to consider some flexibility on number 17 about the 4 hours will not be reimbursed, and that there might be some exceptions related to acuity, or we have people that are there for 3 hours and 50 minutes and they've received all of their core services, and it's because, or we're arranging for a doctor's appointment and doing care coordination as part of it, that we could look at some other outlier situations, and the center really should be, because they've delivered a day of care, but they're not getting paid for it.
And when you say acuity, for people whose condition is such that after 3 hours they're exhausted.
Yeah, well, right now we've opened up our day program license piece more, and because it allows us more flexibility at the time of day that they come, or it's related to transportation.
Right.
And so a lot more people are, and we have a scholarship program, so we can let other people access it now. But some people really can only do that 2 hours because of their acuity level, but they're still getting really critical care in those 2 hours of time at the center.
Another example would be weather, severe weather. We're limited in our ability to, we send people home. We have to if the weather's really, building in paradise or something.
Yeah, good point. Good point. Do you think that's something that could be considered to be changed? What's your thinking, John and Ed?
I do.
Denise and Jean?
Sure.
This is one of those areas that I am with Lydia, I sort of get confused a little bit about because it is a rule that's in the regulations, and I thought we could make we had some amount of liberty to create different rules or amended rules in these SOPs. So I'm not sure. I certainly understand the need that Celine is talking about, and we certainly would want something clearly defined so it was, appropriately used.
Yeah.
But I don't know how we would work that then if the regulations say what.
Yeah, well, I'm just saying, I think it's something we can look at for change. It makes sense. It's how and when that's accomplished that I'm not clear on.
Well, can I say something? So, no, if you all could, because I know this has come up in the long history that Denise and I, some of the others in here have, that this has come up in the past where the flex regs are in licensing, but CDA has the program. If you all could initiate a process internally to at least get that flex authority moved over to CDA or added to CDA, then it seems like there's some authority to, have centers come to you with program flex models. You guys could analyze them and then make some approvals without having to change regs and go through a whole lot of very expensive and lengthy processes. So I think we've heard so much about flexibility from the plans, from consumers, from the providers, that to me that would be a really key area that if you could do something internally, then we could all support that effort and help you, move it forward. I just wanted to throw that out because there's time. It's only the 1st of February.
Yeah. I guess, one of the things with program flex, I'm just thinking out loud that comes into play, and we know from our discussions with licensing around program flex is how to put into place a process for that is doable at the administrative side and also is clearly outlined for providers. So in other words, are we talking about flex for all requirements? Are we talking about limited flex in certain areas and a clearly defined set of standards that need to be met in order for a flex to be reviewed and granted? All those things come into play on the operational side of it. So aside from just making a change in the statutory and or regulatory language having to do with the authority to do flex and so forth. So that's why I'm temporizing here a little bit, is there's a bit operationally involved in putting in flex authority that needs to be thought through so that people don't think, well, we put this great thing in place, and then it gets frustrating because it's not happening.
Understood.
Good. Okay, Celine, thank you for bringing that up. So anything else on 15 to 25? Any other suggested changes or thoughts? Then let's continue the services section, which is 48 to 62. And it looks like there were no comments sent in on this section, which is, again, the continuation of grouping 8.
Ryan, do you have comments on the staffing?
Which one are you looking at?
We did kind of have a conversation.
Celine, speak up so that
I'm sorry.
we can hear.
I'm mumbling in my hands. I'm trying to remember the conversation, but we talked about the quarterly, the quarterly look back, and would if a center had a substantial drop in their ADA, like for us that happens usually November and December. So if you're basing it on the previous quarter of how you're having to staff, but if you had a significant drop in ADA, you have a reset of the clock to really make that because of the financial implications of that.
And also, I wanted to recommend that this be a staggered increased staffing requirement, because you can have a very small increase in ADA, and it can require you to hire new personnel, and then you have a drop in the ADA, very quickly, and now you have the new personnel in place. And so there really is a need for clarity and greater ability to, well, I think it's really ensuring that we understand what the meaning of the current language is, and that it's actually reflecting the ability to have the staff in place that meet the licensing standard of safety without having an artificial imposition of an additional position.
I think when we moved towards this in the SOPs, it was that movement towards flexibility rather than our very archaic old system of when you get 51, you have to have that 0.5. It was trying to capture that, but it still needed some work about how that gets interpreted. And I can't remember if you guys were involved in this first round, but yeah, I think we tried to build in a little bit more clarification on the existing staffing ratio when requirements under number 52, where we gave an example of, this was actually a Jill Youngling Memorial reinterpretation of that old statute, that when we look at that previous ADA's experience dictating what the staffing requirements are, we sort of broadened our understanding of that to say the experience for the previous quarter is that every Friday your ADA is dipped lower, so every Friday we will consider the staffing ratios at a lower rate as long as it's demonstrable in the record. And so we tried to clarify that there. So I just suggested you guys have some particular language that you think would help, put a finer point on this issue. Send it in, and we'll put it in here.
Yeah, we'll look at
So
it.
Celine and Diane, if you could look at that carefully, and anyone else certainly, but if you could make sure to take responsibility to send that in the next 10 days, that would be really helpful as we prepare for the next meeting. So thank you both for bringing that up. Okay, anything else in 48 to 62 in the services that anybody wanted to highlight? Okay, so let's, again, everybody will have one more chance at this at the next meeting or before the next meeting. Let's go on to the organization and administration. That's the number 8. That is starting with 35 to 47, which is page 7. Thank you. And that's number 8. On the far left. Anybody have any suggested changes on this first grouping? There's a second grouping, 66 to 75, but let's look at 35 to 47. Any suggested changes? Doesn't look like any comments were sent in, but that doesn't mean others don't have comments.
May I ask where the qualifications are described here?
The qualifications of?
I don't see the description in this section. Organization and administration.
So for program director administrator, they refer back to Title 22 requirements for specific educational experience.
So it's no need to describe.
It's not here, yeah. Good question, Viviana. These are the things we want to double check. Okay, well then let's go on to look at the second set of organization and administration, 66 to 75, and that is page 13. So there are some comments here on 66 and 67 and 71. So whichever group worked on this set, do you want to describe your comments? Is anyone here who worked on this group?
I think that, well, Jeannie and I sat in on each team. So yeah. I think this was Pam's group.
Okay, good.
Mark's, and he's not here today.
Okay.
Who else was in
Pam had to leave.
But I think that this discussion about the sharing of information between the plans and the providers is something that we're trying to address, at least generally, in our new sections that we talked about, the provider plan relationship. And then I think the clarifying, the greater clarification is that this is something that's contractually between the plans and the providers that everybody sort of better understanding their roles and relationships needs to know that if the plans want certain kinds of communication and they don't feel like they're getting enough from the providers, that's a function of their contracting. So,
Yeah,
but I do remember
I
this
agree.
discussion. It took up a good deal of our work group discussions with that group.
Well, and that just back to her comment that when she was saying that the plans don't know what we're doing in our center. I mean, they have a plan of care in front of them that has a frequency and which discipline is involved in the frequency of all of that. What you don't have in front of you is the progress or the, that's the IPC doesn't
Right.
have that piece of how they're, what progress they're making towards those goals.
Part of the conversation at the last meeting was also the infrastructure to support that communication. And I think was from Los Angeles that in the future, electronic communication will support that. But who will pay for that?
Exactly. It's expensive.
Good point. Lydia?
And my the tension here for me in thinking about the beneficiary needs, the plan needs, the center needs is the tension between what is important to retain some statewide consistency in terms of policy and some structures, and where do we want to maximize flexibility? Because if you think about LA or San Diego or Sacramento eventually, I mean, there's 4, 5, 6 plans who all have their own ways of doing things, and our centers are understanding that, and it's part of this reality. On the other hand, if we begin having 21 plans asking for 21 different levels of detail and 21 ways of communicating and 21 da-da-da-da-da, the capacity of a center to operationalize that, and you talk about your work and operationalizing of a small center that's focused on serving people, hands-on, it doesn't have a large back office operation, is going to start to drown the center in process that isn't productive. So I think that's just a tension I wanted us all to be aware of as we have these discussions in our work groups and all that. And I don't have an answer to it. I just want to acknowledge that it's there, and we need to be cognizant so that we're not taking away from patient care as we add more and more requirements on the centers. And we're not paying the rate that supports that.
Right.
I'm sure centers would be happy to do all that work for the appropriate reimbursement level.
Absolutely.
Okay. Oh, go ahead, Ed.
So I guess that is really part of the discussion of this work group looking at integrating the individualized care into what the plan has. Beyond just the plan of care, but looking at certain key points in time in the implementation of that plan with progress notes, et cetera. How does that information get reported to the plan in a way that plans can use it?
There are great systems out there that allow you to review that on time and point. Just open the file and you can do
Right.
review.
Yeah, and they see a plan of care and they don't know the next steps of that. And if they saw our IDT note,
Right.
they would know really, how that person is really doing at this moment in time with the whole team's input into that.
Right. So that's just a thought that as we look to that discussion, maybe it needs to be a little broader than just IPC.
And I think it also goes to discussions that we may have about needs for revising the care plan with in mind what might be standardized fields that everybody wants, but
Right.
capture those, those fields.
Yeah.
So I think this moves us, if I could, into group 10, which is the IPC. And we have 2 items that I can find that are that are number 10, number 6, and number 65. The thing about the IPC to remember is we have agreed to have a work group post this series of meetings to really focus on all of the dimensions of the IPC, including the comment that Denise just made and other comments that have been made. So we have in the SOPs number 6 and number 65. Were there any others, Denise, or Jane? That's the only ones I could find.
And they're color coded wrong, I'm embarrassed to say. But,
That's okay. That's why we're using
yeah, I think that
acronyms.
there's some
I'm
other
working
references that IPC is actually stated
Right.
in that we don't have, like it's
Right.
in number 63, it's in number 64.
Right. It's
talking
mentioned.
about authorization of services.
Right.
But I think, key points from my perspective are that the Medi-Cal Title 22 requirements for IPC define what must be in the individual plan of care, the form for authorization of services. I don't think there are any fields that anybody would object to. They're all pretty basic things. So anything that we would look at doing to change the form itself would, could conform to what we want to look to in the future and what managed care plans need, et cetera. So I think these are very general references here. So
There'll be a lot more detail.
right. So the detail is really in the form that we create that needs this thing called the IPC.
And I think,
Really?
I hate to bring this up, and I will, in the new
Shall I be ready?
promulgated CBAS regs from the feds, there are some very specific requirements about person-centered care planning and what sorts of information need to be included and reported out, et cetera. So I think it would be necessary to be familiar with those requirements in any sorts of discussions we have about plans of care related to this work group setting.
So, and again, just to underscore, we're going to have an IPC separate work group after we're done with this project, which is the STCs and the SOP. So kind of a future-oriented group. Okay. Well, by my count, we have now done the SOPs. Is that possible? Wow. So we finished going through the STCs and we finished going through the SOPs. That's awesome.
Excellent.
Nobody thought we could do it. You guys are great. So let's just summarize what's going to happen next in anticipation. Oh, I'm going to do public comment in a minute. I thought we should talk about sort of what's going to happen next. So if anyone has comments on that, people can make comments too. So this was meeting number 3. Meeting number 4, which is our last in-person meeting, for those of you that are able to be in person, we will spend the first part of the meeting, and I hope it won't last very long, this part of the meeting, to review the recommended changes in the STCs and the SOPs. Those will be sent out to all of you in advance, so you can look carefully to see if we've recorded everything per our discussions here. The second half, or I hope 3/4 of the meeting, will be focused on a number of issues that we've labeled future issues. They're not necessary in the STCs and the SOPs, but they're issues that we want to talk about. IPC is one, the flexibility of the model is another, the pilot that's going on the patient-centered health home, a number of issues like that, and we'll gather up all those issues and send those out in advance so you can be thinking about them. And any materials that we have on those issues we'll also send out in advance so that everybody can be prepared to have a really fun discussion, I think, about what's possible in the future. But our first order of business at our March meeting will be to review your recommendations. And then those recommendations will go to DHCS and CDA and will be incorporated as appropriate into the different documents that have to be prepared for CMS. And then we'll have a webinar in April to recap the work moving forward to the submission at the beginning of May. What did I forget, Jeannie and Denise, in terms of next steps?
I have about 8 of them here. So you want me to go through all those now?
Sure. Why don't you, just so everybody.
So the action items that I have, and everybody on the notes is backing me up here, so in case I missed something, that we had agreed that we were going to put together what we talked about at the top of the meeting today with regards to waiver timelines. So we'll write all those up and summarize them and post those on the website. And we always send a distribution notice whenever we change the website, so we'll let you know when those are up. the hierarchy of authority that John described. We'll do an abbreviated version of that, summarized and posted. We were going to, what are the plan requirements versus the provider for IPC? So we were going to be looking at what plan requirements are versus provider requirements for care planning. So that'll be sort of, I think, a lead into our IPC discussions. Regarding the dashboard, we're going to make some changes to what we showed you today, and we're going to pop those up onto our website once we get all of the approvals internally, and we're going to include some of the things that you suggested, like include private pay participants, et cetera. If a new center comes into business, we'll list that and where. Lydia had made some suggestions regarding the small work group and looking at quality. So I think that that's a work group activity going forward.
That's a future
next time. We were going to look also at TAR authorization policy in particular, and where plans have different practices, and look for opportunities to make some of those more consistent. And then we're going to send out a summary before the next meeting of the future issues that you just described. So that's everything I have, but I'm sure there's a few more that we'll find, and we'll add it to the summary list.
Right, it'll all be in the meeting summary. Yeah.
And there was that discussion of doing some sort of pilot to look at adult day health care as an intervention and its impact on service use. That was a future thing. But,
yeah, definitely for the future. Yeah. Good.
And then if we have time, Bobby, I think pursuant to Diane's comment, just a couple of patient vignettes or
case studies
for next time.
Yeah, definitely. Nina, did you want to add something?
No, that was it. I was going to say.
Okay, good. Oh, Lynn.
Lynn's
taking a note.
By Celine, and some others to send language related to the SOP and STCs regarding staffing requirements, and we did.
Good, thank you, Lynn. So there's probably a number of other next steps, but we wanted to just review those. So a lot of work to do. DHCS and CDA have done, I think, a remarkable job in between the meetings, gathering and filtering and organizing the materials. They've just been super to work with, and really, thanks to them and all of you, we got through this today.
And to you.
Oh, yeah.
Oh, yeah. They need,
Master.
So now I'm going to stop, and let's open up the meeting to public comment. So first, let's hear from any members of the public that are not work group members. Any comments they'd like to make. If you could say your name and if you're affiliated with an organization, and if you could limit your comments to about 1 minute, and then we'll hear from the comments that have been written in by the 60 to 75 people that have been listening into the call. Tremendous interest in this discussion. Yes, Jill, why don't you start?
Jill Youngling from
Jill, will you stand up so that the microphone can pick
I've
you
never
up?
been accused of being quiet.
Yeah. You like those guys.
Jill Youngling from Eschaton Adult Day Health Center. I made a little note when Pamela made the comment about the plans not knowing what we're doing, and I just was pleased to hear Celine's comment. Our IPCs are typically around 20 pages long with so much information. I can't imagine any other provider group that is asked to provide as much information about the participants. I agree that an outcome statement on them would make a huge difference, and just sending them a quarterly report would make a huge difference. My other comment is I just congratulate you all for the level of civility and interest and activism here. It's really a nice thing, because over the last several years, you know, many of us have been adversaries, and the sense here in the room is that people are pulling together, and I congratulate you all on that.
Thank you, Jill. Thanks, Jill. Yes, please.
Hi, I'm Nina Weiler-Harwell. I'm an ARP. I can also speak loudly. So I'm sorry I missed the last meeting, but I'm really glad to be here today. And as an organization that represents 3.2 million Californians, I'm hearing so much focus on access, choice, and quality. And that's great for our many members that are using these services. I was very happy to see that removing the nonprofit requirement was basically very easy. Should have been there in the first place, in our opinion. Speaking of access and choice. We also agree with the call to, and I know this may not be the right venue for it. There are other venues, but the call to increase the provider rates, especially as the other Nina pointed out, given the increasing acuity of this population. But we will definitely add our voice to that. Also, enjoyed the conversation. I see where we all are going about increasing flexibility in terms of adding new providers. I have to get a little more information on that. But again, just looking at how the number of providers have declined with 6 months, we have some serious issues, as everyone knows. Look forward to further development of the dashboard. Also, the quality work group and the metrics for quality, such as we see, for example, Covered California, which is somewhat different, but has come out with quality ratings. We'd love to see that. Finally, I do have a question. So CMS just came out with a requirement that waivers include family caregiver assessments. Is that going to apply to this? When is that kicking in? Does anyone know?
I know that that's included. I don't know when it's kicking in.
So is that going to be part of this waiver renewal?
I would assume that there's many locations to collect that information of family care assessment, whether it's at this particular provider type level. I don't know that yet. I know that for some of the waivers that provide home and community-based services in the home, that assessment will definitely be added.
Well, I'd like to see whatever language is included.
So I think I would assume that we would definitely incorporate some element of that family assessment in the health plan's assessment of, so that they can create a comprehensive care plan.
Yes, if the caregivers can't do their job, then these folks end up institutionalized. We'll follow up on that. Thank you.
Thanks, Nina. Any other public comment from anyone that's here?
Only gonna ask, right?
You're next. Okay, Jeannie, how about any comments from the stakeholders that have been listening in?
Starting back at the beginning, we had what services are considered to be unbundled? Is transportation in rural areas one of these services? Do you want to comment on that? Or is it a question?
Yeah, I don't think there's any need to answer all the questions, just to hear what the questions are at this point.
Participants' characteristics questions definitely should be revised. The same thing should be done with the MSSR questions. To another question, to the reimbursement, the minimum wage is going up this July and then in January. Will this be factored into the reimbursement? And how and where can we have access? I thought you would want to know. Where and how can we have access to the spreadsheets that we were talking about? And we can let them know.
Yeah. So I think we posted everything on our website. We will post updated matrices after this week's meeting, and we'll send a distribution notice out to let everybody know that it's posted. Right?
To be relevant in today's healthcare environment, we must align CBAS quality and outcome metrics with what the hospitals and MCOs are measuring and interested in. For example, hospital readmission rates and diagnosis, etc. It looks like the CDA dashboard misses that completely.
We should all have that data.
Yeah.
Good point. So I think it's great to hear that people are not only listening, but sending in important and thoughtful comments. So it's really, really helpful. And I think between the stakeholder input that already has been collected and comments like this, it really does help to advance the conversation. So thank you. Thanks to all of the stakeholders who were listening in on the phone. I know that's the hardest part, is to track a conversation when most all of it is here in the room. So we've gone over the next steps. We've heard public comment. I want to just congratulate you all again for getting through the STCs and the SOPs. I'm kind of shocked myself. I did have a backup plan in case you didn't get through them. If anyone has any further comments after the meeting, you can send them in to the Department of Aging or call in any thoughts you have, and we will begin preparing for our March meeting. Again, the March meeting will focus on two major topics: a review of the recommendations of the work group for changes in the STCs and the SOPs, and then I hope most of the time will be spent talking about a number of the future issues that have been identified. So does anyone have anything they'd like to add? Any members of the stakeholder work group before we adjourn? Yes, Lydia.
Just to Ed's remark earlier about the new CMS regs, does it seem to, I have not read those through thoroughly, just little summaries. Does it seem to you that we need to be attentive to some of the new direction or instructions from them in our process, or are they really tangential to our work?
I don't know that they're, I think we do need to pay attention to what's in the regs.
Okay.
Knowledgeable about them. The guidance hasn't come out from CMS yet, so the way the regs are being interpreted by CMS may not be evident from the regs as written.
Okay. And is this family caregiver part of these same regulations?
Well, the person-centered service plan that's described in the reg talks about how that plan, among other things, needs to reflect the services and supports paid and unpaid. That will assist the individual to achieve identified goals and the providers of those services and supports. So you're talking about family caregivers, but by extension, including natural supports. Natural supports are unpaid supports that are provided voluntarily to the individual. So.
Okay. Then you have another aspect of patient-centered plans.
Yeah.
And sometimes the client or the patient is not able to actively participate. The family member as a practice have a role.
Right.
So in a way we need to use all this. So the family needs to be part of it.
So just as an information point for everybody here, the reg is CMS -2249-F /2296-F.
Can you say that one more time? Oh, there we go.
Okay.
CMS -2249-F /2296-F. And this is a final rule. So.
Okay. Yes, Ruth. Thank you, Ed.
You're welcome.
So, and this is just sort of a tangential comment. One of the things that had been put on the parking lot early on, and John addressed one today, which was about expansion, was the idea of having either standards or regs for specific populations. And we talked about dementia-specific or maybe other specialty populations that are being served and what those standards might look like. And I didn't know if there's going to be a place for us to have, is that going to be discussed, or how, what we thought we might be dealing with that in terms of
Oh, it's a parking lot.
that was the parking lot.
Yeah. So I think we should put that on the agenda for our next meeting and see how you all would like to address that now and later. Thank you for bringing that up, Ruth. I'm sure it's somewhere in the notes. It's good to have it raised up again and reminded. Thank you. Okay, a big shout out to the CBA staff who set up all the electronics, PowerPoint, the microphone, the fancy board. You guys are awesome. Thank you so much. And with that, I will adjourn the meeting 7 minutes early. Never say you never got out early. Thanks, everybody.
Thank you, Bobby.
Thanks, Bobby. Nice job.